This treatment plan is the recommendation of Dr. Gary Glassman. Kerr Endodontics is a medical device manufacturer and does not dispense medical advice. Clinicians should use their own judgment in treating their patients.
Well, there's two common emergency situations that a patient will present with. When the pulp is vital and they have an irreversible pulpitis, or when they come in with a non-vital pulp and an acute alveolar abscess. We handle those completely differently. When a patient comes in with hot and cold sensitivity, spontaneous pain, and they have an irreversible pulpitis, the objective is to remove that irritating pulp. Once we make access into the tooth, into the pulp chamber, then we take our hand files and we start to shape the root canal. By going through the process of shaping, this will ultimately remove that inflamed pulp. It's not necessary to do a complete shaping of the root canal. We merely want to remove the pulp tissue that's irritating and provide the patient with that relief. Once that's done, we place an intracanal medicament of calcium hydroxide in the pulp chamber and very gently use a lentulus spiral to place it into the coronal and middle third of the root canal. Once that's done, we put our temporary filling and then we dismiss the patient with the appropriate non-steroidal anti-inflammatory. Now, when a patient comes in with a non-vital situation, quite often they come in extreme pain and often swelling. So the basic tenet here to relieve them of their discomfort is to affect drainage, either through the tooth or through the soft tissue. If there's a soft fluctuant swelling, we want to take a fresh, sharp scalpel and incise that area in order to affect the drainage. If we can get drainage through a tooth, that's even more desirable. But it's very, very difficult to anest those patients who are swollen because there's an acidic environment around that tooth which will push the anesthetic molecules away, making it very difficult to anesthetize. So we want to get in quickly and we want to get out quickly. Incision and drainage is often the way we can relieve that patient's discomfort. But often they come in where they don't have swelling, but they have severe pain. And the best way to affect drainage is by making access into the tooth. And quite often, as soon as we make access into the tooth, we see drainage of pus and or red blood cells coming out at the same time. At this point, a decision has to be made. Do we close the tooth or do we keep it open to drain? If you can't stop the drainage, then my recommendation, and what I do in my practice, is I have the patient go on warm saltwater rinses for the next 72 hours. I bring them back, I re-irrigate the canal. If drainage stops, I instrument the canal very lightly and place an intracanal medicament of calcium hydroxide and then place a temporary restoration. Once I place the intracanal medicament in, I'll reappoint the patient for the next week and I'll complete the endodontics at that point. Sometimes the patient will come in distress, very anxious and very scared, and they come with a diagnosis of a non-vital tooth that has periapical involvement, where the tooth is very sensitive to percussion, they have spontaneous pain, and at that point, the patient may not want any treatment to be given at that point. In my practice, what I'll often do is I'll medicate the patient. As long as their medical history allows it, and as long as they're not allergic to it, I'll prescribe amoxicillin 500 milligrams 3 times a day for a week. And when the patient is comfortable, I'll bring the patient back, initiate, and complete the endodontics at that time. There are some schools of thought that say not to leave a tooth open to drain. In that case, you may have to have that patient stay in your chair until the drainage stops. It may stop after 5 to 10 minutes, or sometimes it can take up to a couple of hours before that drainage does stop. Now, once we've done the subjective interview and got all the patient's information and they've talked about it, we've listened to their chief complaint, and once we've satisfied ourselves that we've gone through the clinical exam, then we have to gather all that information, we have to assess it, and then once we've assessed it, we come to a diagnosis. Then we have to have an action plan and prescribe the appropriate treatment for the root canal procedure, either to get the patient out of pain immediately or to complete the endodontics definitively.